الرحيم. أنا برحب بحضراتكم وبشكر شركة فاركو ويوروبيان كومباني على استضافتي النهارده. احنا الحقيقة النهارده هنعمل حاجتين. الحاجة الأولانية إن احنا هندي برزنتيشن على الانتراتراين جروس ريستريكشن، والخطوة اللي بعديها إن احنا هنستضيف معانا بروفيسور جيرار فيسر من هولندا، وهيدينا توك على الكوفيد 19 and pregnancy and delivery. الحقيقه او الستارت باي ان انا اكلمكم على الانتراتراين جروس ريستريكشن. انا عارف انه دلوقتي كل التوكس على الكوفيد والكورونا والى اخره، لكن الحقيقه ناس كتير قوي كانت طلبت مننا ان احنا ندي some sort of scientific lecture على موضوع common ومهم، وكل الاوبستريشن والجاينيكولوجيست بيبقوا يعني انترستد ان هم يعرفوا ايه الليتست ابديتس فيه. الانتراتراين جروس ريستريكشن باي ديفينيشن it is failure of the fetus its own gross potential associated with increased morbidity and mortality. الجروس بوتنشال بتاع الفيتس، كل فيتس ليه جروس بوتنشال بتاعه هو شخصيا. طبعا ده بيختلف من فيتس لفيتس، من ماذر لماذر، من انفايرمنت لانفايرمنت، من كونتري لكونتري، لكن في معظم الاحيان الديفينيشن of that the estimated fetal weight is less than the 10th percentile for this fetus in this environment ده بيبقى satisfactory. الحقيقه below the 10th percentile دي بنرجع نقسمها تاني وبنقول ان below the 10th percentile ده gross restriction، لكن لو below the 3rd percentile ده بيبقى severe، وبالتالي الديفينيشن نفسه بنقول ان هو بيحصل تقريبا ما بين 3 to 10% of all pregnancy. لو قلنا الديفينيشن الاوسع اللي هو 10% يبقى ده معناه ان احنا 10% of all pregnancies. لازم نفهم قد ايه this is important، لانه مثلا اديكم مثال ان احنا دايما بنقول one of the common complications of pregnancy مثلا preeclampsia. preeclampsia بتحصل in 1% of pregnancies، ف 10% of pregnancies يعني واحده من كل 10 ستات حوامل بنقابلهم في عياداتنا وفي مستشفياتنا عندها intrauterine gross restriction. البرينيتال موربيديتي ومورتاليتي much higher in IUGR fetuses than the normally growth fetuses. 20% of all stillbirths are IUGR. The incidence of intrapartum hypoxia is almost 50% of these cases. The only way to avoid all these complications is early identify so that you can manage properly. So the main issue in intrauterine growth restriction is diagnosis. How do you diagnose early IUGR? One of the recent theories about intrauterine growth restriction and how it affects the outcome is not only the effect على pregnancy وعلى labor, the effect على the future of these fetuses. Fetal programming is a theory that suggests an environment surrounding the fetus during its developmental phase plays a very important role in determining the disease risk during its later stages of life when it is an adult. وبالتالي لو كان الفيتس ده during its intrauterine life تعرض ل environment مش كويس، ناقصه حاجات، حصل له deficiency، ادى الى ان هو يحصل له intrauterine growth restriction، later on this intrauterine growth restriction will make this fetus adapt to the environment اللي حواليه، يبتدي يعود نفسه على الانفايرمنت ده. لو عود نفسه على الانفايرمنت اللي هو عايش فيه اللي هو فيه deficiency، بعد ما بيتولد ويجي له abundance of food والى اخره يبتدي يبقى more prone to disease. والديزيز اللي بيبقى برون ليه هو كل الديزيزز اللي احنا بنشوفها دلوقتي في الادلت لايف: دايابيتس، اوبيزيتي، هايبرتنشن، اثيروسكلروزس، هارت ديزيز، كدني ديزيز. يعني كل الديزيزز اللي احنا شايفينها دلوقتي كومن في البوبوليشنز ان ادلتس، جزء كبير منها سببه الانترايتراين لايف اللي كان متعرض فيها وهو لسه فيتس. الكلام ده مبني على ثيوري اسمها باركر هايبوثيسيس. ديفيد باركر في الثمانينات طلع ثيوري او عمل ثيوري اسمها ذا ثريفتي فينوتايب. باختصار قال ان هو if the fetus is exposed to low nutrition it will adapt to this particular environment. النيوترينز هتبقى ديفوتد او دايفرتد تو مور امبورتنت اورجنز على حساب ليس امبورتنت اورجنز، اللي هي بنسميها ريديستريبيوشن اوف ذا كاردياك اوتبوت. This redistribution of the cardiac output هيبقى يؤدي الى ان الفيتس ده يبقى عنده sorts of problem in certain organs، الليفر، الكدني، الفات distribution. كل ده يؤدي الى ان هو لما يتولد وبعد الولاده يبتدي يكبر، يجي له enough nutrients والى اخره، يبتدي يحصل له the so called metabolic syndrome. الميتابوليك سندروم ده عباره عن ايه؟ سندروم اوف obesity, hypertension, heart disease اللي احنا شايفينه بيحصل في العالم كله وبالذات في مصر. كل ده في according to Barker بيعتمد على الانتراتراين environment، especially اذا حصل للفيتس intrauterine growth restriction، ودي theory how this occurs، ده so called fetal programming. نيجي بعد كده بقى للانتراتراين growth restriction، وكلنا عارفين الانتراتراين growth restriction في many ways to classify. One of the classification is a phenotypic description of IUGR if it is symmetric or asymmetric. كلنا عارفين ان السيمتريك IUGR هو عباره عن انه الهيد circumference واللينث والويت كلهم reduced below the 10th percentile. Usually it is either due to decreased growth potential of the fetus or extrinsic condition that are active in pregnancy. الاسيمتريكال اي جي ار هو ده اللي احنا بنسميه الريديستريبيوشن كاردياك اوتبوت، او هو ده اللي بيحصل في الريديستريبيوشن كاردياك اوتبوت. الفيتال ويت بيبقى ريديوست بس اوت اوف بروبورشن ما بين اللينث والهيد سيركمفرنس والويت. يعني الهيد سيركمفرنس بيتحافظ عليه، هيد سايز بيتحافظ عليه، والابدومين سايز هو اللي بيبقى صغير، فالويت يبقى قليل برضه but in asymmetrical pattern. نيجي بعد كده للاتيولوجي اوف intrauterine growth restriction. والاتيولوجي اوف intrauterine growth restriction الحقيقه very diverse. عندنا many factors، maternal وبلاسنتال وفيتال. كلنا عارفين لما بنيجي نذاكر الاي جي ار بيقول لنا والله يا جماعه الاي جي ار ده في جزء منه ماترنال فاكتور وجزء بلاسنتال فاكتور وجزء فيتال فاكتور، لكن الحقيقه لما نفكر فيها هو في جزء كبير قوي مشترك بين الثلاث حاجات دول. يعني لما نبص على الجراف اللي قدامنا ده هنلاقي انه في اوفرلاب ما بين الكوزس وبعضيها. يعني ماترنال ميديكال انفلونس مثلا زي الهايبرتنشن ده it is a maternal factor، لكن الهايبرتنشن ده بيؤدي الى بلاسنتال ديزيز وبالتالي في بلاسنتال فاكتور. تمام. عندنا الدراجز المذر بتاخد الدراج، لكن الدراج ده بيعدي للفيتس وبالتالي ممكن يعمل فيتال مالفورميشن وبالتالي it is فيتال كوز. عندنا حاجه زي الانفكشن زي الملاريا زي التورش زي السيفيلس، دول maternal disease بيحصل لكن بيؤدي الى placental problems وبيؤدي الى fetal infection، وبالتالي there is an overlap between factors. كل الفاكتورز دي نقدر نشوف ان في حاجات موجوده، لكن معظم الحالات بتاعت الاي جي ار ما بيبقاش فيها any of these factors، بيبقى فيها placental disease لكن مش قادرين نعرف ايه هو الديزيز او ايه هو السبب بتاعه. نعمل ايه ودايجنوستيك تولز؟ طبعا كل دي حاجات لازم تتعمل في اي حاله اي جي ار. لازم نعمل tests to check that the fetus is normal، لازم نعمل clinical examination، لازم نعمل ultrasound، لازم نعمل دوبلر. هنشوف طبعا مع بعض في next slides ازاي ان احنا نقدر نعمل evaluation ل a case of intrauterine growth restriction. اول حاجه لازم identify who's at risk، طبعا دي مهمه جدا، لكن لما هنبص على الريسك فاكتورز اوف اي جي ار هنلاقي ان هم الحقيقه حاجات كتيره جدا. يعني تقريبا كتير جدا من ستاتنا الحوامل اللي هم بيجوا لنا في عياداتنا وفي مستشفياتنا ار ات ريسك بور ماتيرنال نيوتريشن. ستات مش بياكلوا قليل، بياكلوا غلط، ودي فيري كومن عندنا بنشوفها كتير جدا. معظم الستات ما بياكلوش البروبر نيوتريشن. بور بي ام اي ات كونسبشن، يعني البي ام اي بتاعها كان قليل، البودي ويت ان ريليشن تو ذا هايت هنلاقيه ان هو كان قليل. لو جالها بريكلامسيا، لو عندها رينال ديس اوردر، لو جالها انفكشنز، لو كان في بور ماتيرنال ويت جين اثناء البريجنسي، كل دول فاكتورز بيخلونا نبقى شاكين ان الفيتس ده ممكن يبقى اي جي ار. نيجي للدايجنوز. احنا قلنا الدايجنوز اوف اي جي ار بيعتمد على انه it is less than 10% of the estimated fetal weight according to age. يعني at 28 weeks المفروض الويت ده يكون الرينج بتاعه مثلا من كيلو لكيلو 400. التنس برسنتايل بتاعه هو 900 جرام. لو كان اقل من 900 جرام على الايدج ده يبقى ده بيبي انتراتران جروس ريستريكتد. طب ازاي اعرف ان هو جروس ريستريكتد من غير ما اعرف هي الست حامل في قد ايه؟ there is no way. فالست اللي هتجي لك في الشهر السابع تقول لك يا دكتور انا حامل في الشهر السابع، تعمل لها الترا ساوند تلاقي الويت ايا كان بقى 900 جرام كيلو وات ايفر. اذا ما كانش عندك proper dating of pregnancy it will be impossible to diagnose intrauterine growth restriction. طبعا مشكله الديتنج ده انه اللاست منسترال بريد كلنا بنشوف ان الستات عندهم irregular cycles، مش فاكره اللاست منسترال بريد امتى، مش فاكره اول يوم من اخر يوم، جات لك وهي حامل في الشهر الخامس او السادس. كل دي فاكتورز بتخلينا ما نعرفش نعمل proper dating، وبالتالي the only way to determine the proper dating of pregnancy is first trimesteric ultrasound, doing the crown rump length and estimating the gestational age. ودايما بقول بليز لما تجي لك عيانه في فيرست تريمستر اعمل لها الترا ساوند، قيس لها كراون رامب لينز، واكتب لها انه according to this crown rump length الاستيميتد gestational age كذا، الاستيميتد ديت اوف ديليفري كذا، وتديه لها على ورقه او على صوره سونار بحيث يبقى ريفرنس معاها. اذا ما كانش في امكانيه في الفيرست تريمستر ان انا اعمل كراون رامب لينز، باي بارايتال دايمتر في السكند تريمستر is okay less accurate بس it is acceptable. مشكلتها بقى لو جت بعد ال 20 ويكس في السكند هاف اوف بريجنسي وبتقول لي والله انا مش عارفه انا حامل في قد ايه، it is impossible ان انا اعرف هي properly يعني more or less growth الفيتس في يعني appropriate for age ولا لا. دول الحاجتين اللي لازم نعملهم، يا اما كراون رامبلتس في فيرست تريمستر يا اما باي بارايتال دايمتر في السكند تريمستر. تو دايجنوز اي جي ار عندنا كلينيكال ويز، طبعا مش هنخش فيه قوي لان الحقيقه اتس فيري ايرونيوس ان انت تقيس السيمفيزس فاندس ريشيو او تقيس الفاندل ليفل. عندنا يعني لازم يبقى في فرق حوالي 4 ويكس ما بين الاستيميتد فاندل هايت بالميجرمنت بالسيمفيزس فاندس ريشيو وبين الاكسبكتد. طبعا يعني مور ليس ده مش اكيوريت قوي وصعب جدا. احنا دلوقتي بنعتمد على الالتراساوند في الدايجنوز. سونوجرافيك ايفالويشن كلنا عارفين انك لازم تعمل فيتال بايومتري في الحوامل ويوجوالي ات سيرتن تايمز ان بريجنسي. عندنا ميزه هنا في مصر الحقيقه عن العالم كله، في العالم كله بيعملوا التراساوند بتوقيت معينه، فيرست تريمستريك، سكند تريمستريك، ثيرد تريمستريك. احنا عندنا هنا في كل حته في مصر كل دكتور في عيادته بيعمل التراساوند للبيشنت افري فيزيت. المشكله اللي بتقابلنا ان لما بيجي يعمل التراساوند ما بيعملش التراساوند مظبوط. بيعمل ايه؟ بيبص في هارت بيت، بيقيس الباي بارايتال دايمتر، يحطه على الشارت يطلع له كام اسبوع، وبعدين يبص على البلاسنتا والامنيوتيك فلويد ويقول لها كله تمام. This is not correct because measurement of the biparietal diameter alone صعب قوي ان انا اعرف منه اذا كان البيبي ده properly grown ولا لا، especially زي ما قلنا ان في حالات asymmetrical intrauterine growth restriction ودول بيبقى الهيد سايز فيهم بيبقى spared بيبقى نورمال. وبالتالي the only way to know if this baby is growth retarded or not انك لازم تعمل معاها الابدومينال سيركمفرنس والفيمر لينس وتقيس الريشيوز من الباي بارايتال دايمتر والهيد سيركمفرنس والفيمر لينس والابدومينال سيركمفرنس. الاربعه ميجرمنت لازم تعملهم كل مره العيانه تجي لك تعمل سونار. مفيش حاجه اسمها انك بتعمل سونار عند 24 ويكس او 26 ويكس او 28 ويكس وتقول لها انت الباي بارايتال بتاعك يساوي كذا اسبوع. This is nonsense. مفيش حاجه اسمها كده. انا لازم اقيس الاربعه ميجرمنت بتوعي واطلع منهم estimated weight واحسب الاستيميتد ويت ده اذا كان appropriate ولا لا according to the estimated gestational age based على الكراون رامب لينس اللي انا عامله في الفيرست ترايمستر، واقول this is appropriate for age, this is below the 10th percentile IUGR او above the 90th percentile ده يبقى ماكروسومي. ان انا ابص على البلاسنتا، انا اقيس البلاسنتا فوليوم، ان انا اقيس الامنيوتيك فلويد، دي حاجات ممكن اعملها في الالتراساوند، لكن الحقيقه دي ما هياش دايجنوستيك، دي سجستيف. ان مع الالتراساوند اللي انا بعمله فور استيميشن اوف ويت بقول والله البلاسنتا شكلها صغير، الامنيوتيك فلويد قليل وهكذا. عشان اقول ان الفيتس ده جروث ريستريكتد this is one thing. عشان اقول ان هو جروث ريستريكتد and suffering from this growth restriction لازم اعمل the so called Doppler assessment and fetal well-being. لانه كلنا عارفين ان الفيتس ممكن يبقى الويت بتاعه اقل لكن لسه ما وصلش لمرحله ان هو يبقى عنده suffering from placental insufficiency. This suffering لازم يبقى diagnosed by Doppler, by CTG and computerized CTG and by physical profile، ودول هنتكلم عليهم بالتفصيل. كلنا عارفين ان الدوبلر اهم حاجه فيه هو الامبلايكال ارتري دوبلر، والامبلايكال ارتري دوبلر دلوقتي بقى سهل جدا ان احنا نقيسه. عندنا جهاز الدوبلر، عندنا الكالر فلو، عندنا احط اشوف الكورد، مش هنخش في التفاصيل ده طبعا، لكن اتس فيري ايزي تو ميجر ذا umbilical artery flow. الصوره اللي فوق على الشمال هي طبعا دي عندنا النورمال umbilical artery flow، وده زي ما شايفينه ان هو المفروض with advancing pregnancy الدايستوليك فلو نسبيا بيزيد in relation to the systolic flow، فاللي احنا بنسميها الانديسز الار اي والبي اي دول بيحصل لهم more or less reduction، يعني بيقلوا. لو في abnormality بتبتدي الدايستوليك فلو تقل لان في ريزيستنس، فيبتدي السيستوليك على الدايستوليك ريشيو اللي هي احنا بنطلع منها الار اي والبي اي تبتدي تقل اب تو انه يحصل ان الدايستوليك فلو يختفي، يبقى ما فيش دايستوليك فلو، وده معناه انه بقى في سيفير ريزيستنس في الفيسلز، فبالتالي الدايستوليك فلو از ابسنت. وبعدين المرحله الاخيره ان لما الريزيستنس تزيد جدا يبتدي يحصل ريفرسال اوف فلو، الفلو يبقى تو ذا اوبوزيت دايركشن اللي هي بنسميها ريفرسد اند دايستوليك فلو. لما بنشخص اي جي ار لازم نبتدي على طول نعمل ويكلي الترا ساوند اند دوبلر. عندنا في تو تايبس اوف بيشنتس. في تايب اوف بيشنت اللي هنتكلم عليه بعد كده اللي هو ما عندوش دوبلر تشينجز، ودول بنسميهم سمول فور جستيشنال ايج، وده مجرد ان انا بعيد الدوبلر تاني وبكمل لغايه اما اوصل ل 38 و 39 ويكس وما عنديش مشكله ان انا اولده ات تيرم. الناحيه الثانيه بقى لو في ابنورمال امبلايكال ارتري دوبلر بنبتدي نفكر في ايه التشينجز اللي موجوده. لو في ديكريز دايستوليك فلو اللي هي الريشيوز انكريز، بفضل اتابع الفيتس ده مور فريكونتلي وبديليفر يوجوالي عند وانس ان انا اطمنت ان في ماتيوريتي اللي هي تقريبا عند 37 ويكس. لو لقيت ان في ابسنت اند دايستوليك فلو بدي كورتيكوستيرويدز وبديليفر على 34 اور مور ويكس. لو في ريفرس فلو لو وصلت 32 ويكس هعمل كورتيكوستيرويدز وديليفر. هنتكلم ان مور ديتيلز. اهم حاجه وانت بتعملها انك انت لما بتتابع العيانه اللي انت عملت لها الترا ساوند وطلعتها ان هي عندها ديلي ان جروث، تفرق بين the so-called small for gestational age and fetal growth restriction. The small for gestational age is a fetus that has clinical evidence انه في smallness، انه الجروث بتاعه اقل من ال 10th percentile، لكن ما معهوش دوبلر تشينجز وما معهوش كوموربيديتي و increased mortality، وده اللي هو بنسميه small for gestational age. النوع الثاني اللي هو الفيتال جروث ريستريكشن، ده associated with poor perinatal outcome مع abnormal doppler suggesting انه حصل fetal adaptation، ابتدى يحصل redistribution of the cardiac output، ابتدى يحصل dilatation في cerebral vessels وconstriction في umbilical vessels. Small for gestational age fetuses do not present the aforementioned changes and display perinatal outcomes similar to those of normally grown fetuses. However, distinction between fetal growth restriction versus small for gestational age clinically relevant because of the wide consensus that it is reasonable to deliver electively fetal growth restricted fetuses early, whereas elective delivery before thereof is no benefit في small for gestational age. عندنا IUGR بقى اللي هو الفيتال جروث ريستريكشن بيتقسم into two types. The first type is the so-called early fetal growth restriction. The early fetal growth restriction usually by definition اللي هو الفيتال جروث restriction اللي بيحصل before 34 weeks. Early fetal growth restriction اللي هو بيظهر عند 28 30 26 weeks، دول بيبقى عندهم severe growth restriction، ودول بيبقى usually معاهم severe hypoxia، ودول بيبقى معاهم usually high mortality وmorbidity. البروبلم فيهم مش التشخيص، التشخيص فيهم سهل. ليه؟ لانه عند 28 ويكس بتلاقي سيفير سمولنس، بتعمل دوبلر تلاقي فيه ابنورمال دوبلر. المشكله فيهم المانجمنت. ليه؟ لان هم فيري بريماتيور، فانت عشان تولدهم ولا تسيبهم هو هنا الديسيجن. الحاله الثانيه اللي هي الليت انتراتورال جروث ريستريكشن اللي هو اللي بيحصل later in pregnancy usually بيبقى مايلد ويوجوالي نوت اسوشيتد معاه سيفير موربيديتي ومورتاليتي، ويوجوالي البروجنوزس بتاعه كويس. مشكلته ايه؟ انك تشخصه، لانك عشان تشخصه لازم تو اكسكلود انه في ابنورمال دوبلر، وفي نفس الوقت عشان تبقى مطمن انك تسيب الفيتس ده لغايه نير تيرم لازم تبقى انت مطمن ان ما عندوش اي سفرنج او اي مشكله. السمول فور جستيشنال ايج اللي هو بقى خلاص لقينا انه عنده اوريدي في دوبلر تشينجز، ببتدي اقسمه اكوردنج للفولو اب بتاعي. انا بقول للعيانه اول ما بتيجي انا هشوف انت في انهي مرحله من الفيتال جروث ريستريكشن. بيتقسم انتو 4 ستيج. الستيج 1 في سمولنس بس في مايلد بلاسنتال انسفشنسي، اليوتراين ارتري والامبلايكال ارتري والميدل سيريبرال ارتري والسيريبرال بلاسنتال ريشيو كلهم ابنورمال، انما لسه ما فيش سيفير تشينجز، يعني ما فيش ابسنت دايستوليك فلو، ما فيش ريفرس فلو. دول ممكن ان احنا نوصل بيهم لغايه 36 37 ويكس، وبعدين ايفن ممكن حتى اعمل لهم اندكشن اوف ليبر، يعني مش ضروري سيزاريان سكشن. ده اللي هو لقيناه، اللي هو بيبقى فيه تشينجز في الدوبلر تشينجز في الامبلايكال ارتري، بيحصل ديكريس في الدايستوليك فلو والريشيوز وبالتالي بتتغير، قصاده بيحصل انكريس في الدايستوليك فلو في السيريبرال ارتري، وبالتالي الريشيو ما بين الامبلايكال والسيريبرال بتبقى تشينجد، لكن لا زال في دايستوليك فلو. نيجي للستيج 2 فيتال جروث ريستريكشن اللي هي برضو عباره عن بلاسنتال انسفشنسي معاها فيتال جروث ريستريكشن، لكن بيبقى الامبلايكال ارتري في ابسنت اند دايستوليك فلو. الابسنت اند دايستوليك فلو ده بيبقى محتاج ان انا اعمل ديليفري. الدليفري امتى؟ عندي مشكله طبعا ان انا مش قادر اولد فيري ايرلي عشان ما ينزلش فيري بريماتيور. فلو لقيت ابسنت اند دايستوليك فلو فقط، ده ستيج 2، اقدر اوصل لغايه 32 34 ويكس وبعدين اديليفر. الانسنس اوف فيتال ديتيريوريشن او فيتال كومبرومايز during labor بتوصل ل 50%، وبالتالي المفروض ان العيانين دول معظمهم يتعمل لهم سيزيريان سكشن. في ناس بتقول تعمل اندكشن وتعمل الكترونيك مونيتورنج، لو لقيت ديتيريوريشن تعمل سيزيريان سكشن. المونيتورنج بتاع العيانين دول اللي هم ستيج 2 بيبقى توايس بير ويك لغايه لما توصل 34 ويكس. ستيج 3 في انكريزد فيتال ديتيريوريشن، في ساينز اوف فيتال اسيدوزس، وده بيبقى ريفرسد ان دايستوليك فلو، وممكن معاه يبقى الدكتس فينوزس فيها changes up to more than the 95th percentile في ال decrease في الدايستوليك فلو. بيبقى في association with higher risk of stillbirth و poor outcome، وبالتالي ال delivery should be by cesarean section usually عندي 30 weeks. لو انا عايز امونيتور قبل ال 30 weeks بعمل المونيتورنج every 24 hours. ستيج 4 ده في سيفير فيتال اسيدوزس، في هاي انسنس اوف فيتال ديث، وبالتالي الحالات دي لازم اعمل لها مونيتورنج لغايه 26 to 28 ويكس بكتير. لو هي بعد 26 او 28 ويكس المفروض بعمل لها immediate cesarean section. دول بيبقى عندهم في reversed flow او reversed atrial flow في الدكسس فينوزس، وبيبقى معاهم سي تي جي تشينجز اللي هي بنسميها الشورت تيرم فاريابيليتي، بتبقى ريديوست او ابسنت، وما معهاش في يعني في السي تي جي او في الكمبيوترايز سي تي جي، ومعاها سبونتينيوس فيتال هارت ريت ديستلريشن، وده برضو اومينس ساين. ده ملخص للي احنا قلناه قبل كده اللي هو ستيج بيزد كلاسيفيكيشن ومانجمنت اوف فيتال جروث ريستريكشن. اخر فيو مينتس هنديكم سمري اند ريكومنديشن في الموضوع ده باختصار او ببساطه. عندنا الموضوع كالاتي: الانيشال ابروتش اوف a fetus suspected of being growth restricted هو ان انا اعمل estimation of fetal weight واشوفه بالنسبه للجستيشال ايج اللي انا عامله في الفيرست ترايمستر. لو لقيته اقل من ال 10th percentile للاستيميتد فيتال ايج يبقى معنى كده ان ده عنده intrauterine growth restriction. تاني خطوه اعملها ان انا ادistinguish between هل ده constitutionally small fetus ولا fetal growth restriction. اللي هو ازاي؟ ان انا اعمل دوبلر اسسمنت، لو لقيت الدوبلر اسسمنت نورمال يبقى ده معناه ان ده كونستيتيوشنالي سمول ومحتاج مونيتورنج، لانه ممكن يبقى في الاول ما عندوش دوبلر تشينجز لكن ليتر اون يظهر فيه دوبلر تشينجز. طول ما فيهوش دوبلر تشينجز هو لا زال فيتال سمول كونستيتيوشنالي سمول فيتس وما يبقاش فيتال جروث ريستريكشن. بعمل ايه بعد كده؟ اي حاله الاقي فيها فيتال جروث ريستريكشن لازم اعمل لها ديتيلد فيتال اناتوميك سيرفي لو ما كنتش عملتها. ليه؟ لان اتس فيري كومن اسوشيشن ان يبقى في كونجنتال انومالي هي السبب في الجروث ريستريكشن، سبيشالي انهو تايب اللي هو السيمتريك تايب. السيمتريك تايب بيبقى بنشوفه اكتر في حالات الكونجنتال مالفورميشن. امتى اعمل فيتال كاريوتايبنج او مايكرو اري لو انا عندي فيتال جروث ريستريكتد فيتس؟ It is indicated لو لقيت في structural anomaly مع الاي جي ار، لو لقيت في soft markers of aneuploidy، لو لقيت في early وسيفير اقل من الفيفث percentile و before 24 weeks، ودول usually بيبقوا symmetrical growth ريستريكشن، وبالتالي دول بيسسبكت ان البيبي ده عنده ابنورمال كاريوتايب، وبالتالي محتاج ان انا اعمل له امنيوسنتيسيس وفيتال كاريوتايب. باخد عينه من الماتيرنال سيرم، عينه بلاد، وابعتها فور seropositivity of certain infectious diseases that may cause IUGR او intrauterine growth restriction. اهمهم طبعا السيتوميجالو فيروس والتوكسبلازموزس وحاجات ثانيه زي السيفيلس والى اخره. اذا كان في positive maternal history او الالتراساوند فايندنجز suggestive of infection، ده شجعني اكتر ان انا اعمل البلاد تيست فور انفكشنز. نيجي بعد كده ليه خلاص انا شخصت ان ده جروس ريستريكشن، وشخصت ان هو هل هو سمول فور جستيشنال ايج ولا هو فيتال جروس ريستريكشن ترولي. ابتدي اعمل انتي بارتم مانجمنت، ابتدي اعمل العينه كونسلنج، ابتدي اعمل لها فولو اب. الفولو اب بتاعها ازاي؟ ان انا اعملها سيريال التراساوند. السيريال التراساوند ده بيفرق according to the stage of the disease. لو كانت هي في الايرلي ستيج بشوفها every 2 weeks، لو هي في الليتر ستيج بشوفها every week، لو في السيفير ستيج بشوفها every day او every 2 days. في حالات ايفن بادميت في المستشفى واعمل لها مونيتورنج ديلي. في الاخر انا كل مره بتجيلي بشوف ايه، بعمل ايه، دي الحاجات اللي لازم تتعمل. بعمل فيتال جروس. تاني فيتال جروس عباره عن estimation of biparietal diameter, head circumference وابدومينال سيركمفرنس وفيمر لينس، واحسب منهم الفيتال ويت، واحط الفيتال ويت ده على الكيرف بتاع الجستيشن ايج واشوفه هو فين. تاني حاجه اعمل فيتال بايوفيزيكال بروفايل سلاش نون ستريس تيست. تالت حاجه اشوف الامنيوتيك فلويد فوليوم. رابع حاجه واهم حاجه هي ان انا اعمل ريزيستنس اوف بلاد فلو ان ذا فيتال فيسلز مينلي امبلايكال ارتري. وطبعا لو كان في ريدكشن في الدايستوليك فلو ابتدي اعمل سيريبرال ارتري واقيس الريشيو ما بين السيريبرال والامبلايكال. ابتدي ايدنتيفاي مين من الفيتسز دول ات هايست ريسك، مين اللي هم عندهم مشكله انهم يتعرضوا ليه انتراتورال فيتال ديس او نيونيتال موربيديتي او مورتاليتي. ازاي؟ بان لما الاقي فيتال جروس صغير وكل الحاجات الثانيه كويسه الريسك قليل. لما الاقي ان البايوفيزيكال بروفايل وحش والنون ستريس تيست وحش والامنيوتيك فلويد فوليوم قليل والدوبلر وحش، ده هاي ريسك. يبقى الفريكونسي اوف فيزيتس اشوفه تاني امتى بيعتمد على السيفيريتي. لو هو مايلد بشوفه مره في الاسبوع، لو هو سيفير بشوفه كل يوم. ده باختصار. Doppler velocimetry of the umbilical artery for monitoring pregnancy with suspected gross restriction is grade 1A recommendation. Normal findings ده reassuring، وبالتالي يبقى خليني اطمن ان انا ما اعملش انترفنشن، ما اتدخلش، ما اعملش اندكشن، ما اعملش سيزيريان، استنى العينه دي اشوفها تاني بعد اسبوع بعد اسبوعين لغايه لما توصل ماتيوريتي. معلومه مهمه قوي، في ناس كتير قوي بتقعد تسالني على الدكتس فينوزس، اعملها كل مره. الدكتس فينوزس والفيتال فينس سيركيليشن بتتعمل لما يكون في ديسيجن على ديليفري اوف ا فيري بري تيرم فيتس. يعني عندي فيري بري تيرم فيتس عنده سيفير ابنورمال دوبلر فايندنجز، وعايز اشوف اقدر استنى اكتر ولا اولدها. لو لقيت في ابنورمال فينس ده معناه ان في سيفير هايبوكسيا، يبقى لازم اديليفر. لو لقيت النورمال فينس لسه او الفينس تشينجز لسه ما حصلتش ممكن استنى شويه كمان. انما ان انا اجي في عينه 36 اسبوع او 35 اسبوع واشوف عندها فينس تشينجز ولا لا، ده ملوش لازمه. بندي امتى كورتيكوستيرويدز؟ ما بين 24 ل 34 اسبوع. according to what؟ according للدليفري. البيبي ده انا شايف ان انا هولده في خلال الاسبوع الجاي او اللي بعديه، بدي كورس بتاع كورتيكوستيرويدز. طبعا لازم يتاخد في كل الحالات، انما الحقيقه في ناس كتير قوي بتديه روتين وبعدين ما يحصلش دليفري فتضطر تديه تاني. طبعا ده مش مظبوط، المفروض اديه وانس ان انا شايف ان الفيتس ده هيتولد within 1 or 2 weeks فور اكزامبل. الدليفري بتاع جروس ريستريكتد فيتس طبعا لازم لو انا هعمل ديسيجن اوف ديليفري، الجول ان انا البالانس بتاعي ما بين الفيتال ماتيوريتي وما بين ان انا يحصل لي انترا يوتراين او انترا بارتم او نيونيتال كومبليكيشنز. البريماتيوريتي ليها كومبليكيشنز بتاعتها، فمش كل فيتس عنده جروس ريستريكشن هولده عند 28 او 26 اسبوع. بالعكس انا البالانس بتاعي ما بين الانترا يوتراين لايف وما بين الاكسترا يوتراين لايف هو ده الديسيجن بتاعي. انا عارف انه فور اكزامبل في الانفايرمنت اللي انا بشتغل فيها، في المستشفى اللي بشتغل فيها، اللي اقل من 28 اسبوع البروجنوز بتاعهم يعني 5% ولا 10% ولا قليل جدا. يبقى انا ما عنديش ديسيجن اوف ديليفري بيفور 28 ويكس في الانفايرمنت ده. انا بشتغل في سنتر عندي ال 24 وال 26 ويكس دول عندهم تشانس 50%. يبقى ببالانس الديسيجن بتاعي ما بين الانتراتراين لايف اللي انا شايفها اللي هي كومبرومايزد وما بين الاكستراتراين اللي هو الديسيجن انا هولد الفيتس ده في انفايرمنت شكله ايه. عندي انتنسيف كير يونت، عندي فنتليترز، عندي دكاتره اطفال هايلين، قدرت ادي كورتيكوسترويدز و الى اخره. بتديليفر امتى؟ باختصار كده، لو هو في ريفرست اي ويف في الدكتس فينوزس اني تايم قبل 30 اسبوع، بستنى لغايه 30 اسبوع، لو وصلت 30 اسبوع بعمل ديليفري. لو لقيت في ريفرست فلو ات اني تايم عند 32 اسبوع، لو لقيت في امبلايكال ارتري ابسنت دايستوليك فلو عند 34 اسبوع او اكتر. الامبلايكال ارتري ديكريست فلو، يعني في فلو بس لسه ما بقاش ابسنت، اللي هو البي اي اكتر من 95 برسنتايل، بنعمل بقى باي فيزيكال بروفايل ونعمل نون ستريس تيست والى اخره لغايه لما نوصل عند 37 ويكس، وبتديليفر تقريبا في الوقت ده. لو في نورمال امبلايكال ارتري دوبلر we deliver these fetuses at 39 to 40 weeks. There is no reason طبعا او no indication ان انا استنى عليهم post date. فاينلي احنا خلصنا، وانا بشكر حضراتكم جدا. احنا دلوقتي عندنا ان شاء الله المفروض هناخد بريك فيو مينتس نجمع الاسئله اللي جت ان شاء الله، وبعدين هنرجع مع بروفيسور جيرارد فيسر هيكلمنا على COVID-19 in pregnancy and delivery. بروفيسور جيرارد فيسر هو بروفيسور اوف obstetrics and gynecology at Utrecht يونيفرسيتي في نذرلاند في هولندا، وهو الحقيقه از جود فريند، واحنا اتقابلنا كتير، ودايما هو كان بيبهرني في المحاضرات بتاعته، وهو الحقيقه من البايونيرز في العالم في الانتراترانجل ريستريكشن بالمناسبه. فاحنا هنخلي الدسكشن في الاخر معاه على الموضوعين الانتراترانجل ريستريكشن والكوفيد 19 اند بريجنسي. هو طبعا ليه هيستوري وباع طويل جدا في اليوروبيان اسوسيشن اوف ماترنال او برينيتال ميديسن في الفيجو، والحقيقه ليه حوالي 400 بحث منشور. هو يعني من الناس البايونير في العالم في الريسيرش in the field of maternal fetal and neonatal medicine. It will be my pleasure to introduce him او ان هو نقدمه ليكم ان شاء الله بعد البريك. هنتكلم على COVID-19 pregnancy and delivery، وبعد ما نخلص هنجمع كل الاسئله ونبتدي نتناقش معاه ان شاء الله. واي هوب ان احنا نكون يعني في at the end of this day حاولنا ان احنا نوصل لكم شويه معلومات على الانتراترانجل ريستريكشن والكوفيد 19 in pregnancy and delivery. هناخد البريك دلوقتي ونرجع لكم بعد شويه ان شاء الله.
afternoon, everyone. My name is Gerard Visser. I'm from the Netherlands. I'm an emeritus professor of obstetrics from this beautiful hospital that you see on your screen now. And I'm a member and the past president of the European of the FIGO World Conference. Please, could you go back to the first slide, please? Because in the meantime, we're already at the second slide. No first slide, okay. I would like to thank Professor go back, please. First slide, yeah, very good. I would like to thank Professor Montas for the invitation and Dr. Carter and the European Pharmaceuticals for facilitating this webinar on corona and pregnancy. Well, corona, as you probably know, is not the right name. The virus is the SARS-CoV-2 virus, and the disease is COVID-19 disease. But I think for all of us, it's a little bit easy to talk about corona. We had all hoped that it would stay in China. That's only very recently. But next slide, please. If you look nowadays, at least in my country, there are 28,000 confirmed cases with over 3,000 people who died. But if you look at the overall population, already 500,000 Dutch people in the Netherlands have antibodies. That is about 3% of the population, so which is much higher than that of the number of confirmed corona cases. Looking at Google yesterday, Google stats, you can see that according to these data in Egypt, nowadays there are only 2,500 confirmed cases with a mortality overall of 183. I don't know if these data are very reliable. In my country, most of us think that mortality is much higher than the 3,000 that have been accounted officially. Next slide. The disadvantage of globalization is the outbreak of pandemics. The advantage is there is a rapid sharing of knowledge. Next. Because if you look at the guidelines in English language, there are already guidelines from WHO, the UK, USA, FIGO, ISWOC, the Ultrasound Society, Canadians, and many more. So in a very short period of time, there are guidelines which almost are all similar to each other. So people generally agree about the right policy regarding coronavirus and pregnancy. Next. Are pregnant women likely to be at increased risk for severe respiratory disease with corona? Well, the answer is yes, given the fact that pregnant women have an increased heart rate, an increase in stroke volume, an increase in oxygen consumption, and a decrease in lung volume. Moreover, they're supposed to be a little bit more vulnerable to disease, given the change in immune system. Next slide. If you look at other coronaviruses, the SARS virus and the Middle East respiratory syndrome, indeed that seems true, because SARS gives an increase in preterm births, fetal growth restriction, higher incidence of maternal ventilation, and data are restricted, but 3 out of 12 documented cases of SARS pregnant women died. With MERS, the data that I could find is 3 out of 13 died. So they probably run a higher risk than non-pregnant patients. Also, next, if we look at influenza and pregnancy, we know that there is an increase in maternal morbidity and mortality, and also an increase in preterm births and low birth weight. But first data, next, on pregnancy and COVID-19 do not show an increased risk for pregnant women. First 38 cases from China with confirmed disease, no severe pneumonia, nor maternal deaths. WHO did an analysis also in China, 147 cases, 8 with severe disease, one patient in a critical situation. So it might be that the risk of pregnant women is somewhat lower. If that's the case, then it is probably because they're women, and women are less likely to develop severe corona. And furthermore, women are usually a little bit younger than the other patients. However, also with corona, women have died, and there's one confirmed case yesterday from the United Kingdom of a 20-year-old pregnant woman. If you look at the data of my country, that's up to the 5th of April, 75 pregnancies, 19 have delivered, for whom most of them vaginally. 40 were just treated at home. They had mild symptoms. 5 were at intensive care, and overall 7 where there was oxygen mask, not one intubated thus far, and no maternal and perinatal deaths. But these data, of course, are still very restricted. Next slide, please. Comorbidities with corona, we know them. From Italy, we now know that also confirmed in non-pregnant women that maternal obesity increases the risk of severe complications with corona. Of the others, preeclampsia or others, we do not know yet. Next. Is there a vertical transmission, and what about the newborn? Most people say there is no vertical transmission, although a recent paper in the JAMA indicates that maybe up to 10% of cases there might be a prenatal infection. Maternal antibodies also cross the placenta that holds for IgG, which is a smaller molecule, but also the larger one, IgM, has been found in the umbilical cord of newborns. Overall, fortunately, there doesn't seem to be a severe risk for the newborns, nor for congenital malformation, at least as far as we know right now. Next. Clinical manifestations of corona and pregnancy. Most common symptoms, fever and cough. Other symptoms, myalgia, malaise, anosmia, sore throat, diarrhea, shortness of breath. Laboratory results show lymphopenia and increased C-reactive protein. And the chest CT shows multiple patchy ground glass shadows in the lungs. And these clinical manifestations next are similar to those of non-pregnant patients. Next. Management of pregnancy. Next. Almost all bodies now have these algorithms for antenatal, during labor, and postnatal care. Here is one of the Royal College. Next. This is a detailed one from China, developed by several experts from China. And next. Here we go to the one of Figo, Poon et al., published in April this year in the Journal of Gynecology and Obstetrics. And I think this is the most comprehensive paper, and this one also shows the clearest algorithms, both for antenatal, intrapartum, and neonatal care. So please go to this paper. It is online, free access, and download it. It's almost 40 pages, and it gives a detailed analysis of all you should know about coronavirus and pregnancy. There are also several webinars. For instance, the ISWOC has a webinar every week or every 10 days. And these are 2-hour webinars in which at the end you can also ask questions. It all starts, all these algorithms, with triage. In other words, if you have a patient, a pregnant woman, is she likely to have the coronavirus or not? If she's negative or doesn't have any complaints and you can't measure, you can proceed with your visit as scheduled, although in these patients you may reduce the number of visits not to expose them too much to the risk of infection in the hospital. If they're likely to be present here on the right side, you have to consider if you should see them in the hospital, or maybe you may defer them to come a bit later if they have no or only mild symptoms. If they have clear symptoms, you have to see them in the hospital, of course. They have to take precautions, hand hygiene, and they have to come with a mask. And your team should be prepared with personal protective equipment to see them in the right way. Next. General recommendations at the beginning of pregnancies, and these are from the Americans. We should try to prevent to spread the virus. So social distancing is extremely important, and if not possible, then there should be dividers between the patient and the others. Any elective or non-urgent visits should be postponed, and each patient should be called to decide on the need for an in-person visit or an inpatient test, or if you can do the visit by phone. Any visit that can be done by telehealth should be done that way. And if the patient is coming to the hospital, no support person should accompany her to the hospital, because if patients are indeed positive, also the partners are likely to be positive. Next. These are the suggested antenatal visits. This one is again by Figo, by Poon et al. The green one are the in-person ones. So those are the ones that need an ultrasound scan. In early pregnancy, a nuchal translucency, dating scan. At around 20 weeks, an anatomy scan. And at 32 weeks, maybe, and that depends on the practice in the different countries, a growth scan. Some other visits at 16 weeks, at 24 weeks may be done by phone or video. At 28 weeks, there might be the necessity to give anti-D immunoglobulin. Of course, then also the patient has to come. And at the end of pregnancy, most people consider that you should see them weekly from 37 weeks onwards. Personally, I think in the low risk pregnancy and with no complaints, then you may also do it 1 week by phone, especially if the patient feeling well, how is the baby moving, and the other week in person. Next. If a patient with suspected probably or confirmed corona will come to the hospital, the patient should wear face mask, and you should assess them in isolation or a private room. Preferably in a negative pressure room, although that usually will not be possible in outpatient clinics. The same holds for operation theater. It should be a negative pressure one, but I know at least in my hospital, they're all positive pressure ones. So usually that is not possible. Healthcare workers in contact with corona cases should wear the full personal protective equipment. Next slide. How do we classify corona disease and pregnancy? The mild ones are asymptomatic or have a mild fever, a mild cough, and no comorbidities. The moderate one have a higher fever, mild dyspnea, severe cough, and or comorbidities like obesity, hypertension, diabetes. And the severe ones, and that's logical, they have a shortness of breath, dyspnea, might be hypotensive, may have coughing of blood, may have a superimposed bacterial infection, or systematic failures of liver, kidney, etc. Next. So, what is the triage of the positive or women with most likely to be positive to have a corona infection? Mild symptoms. Consider if you may look at them at home, so not have them not come to the hospital unless severe necessary. The ones on the right with some severe symptoms, yes, you have to admit them to the hospital. This will be a multidisciplinary treatment. You need intensive care doctors, you need lung doctors, etc., to decide what to do. And with the moderate systems, it's very difficult, but important at triage to see if you think it's necessary to admit them to the hospital, or if it is still possible to send them at home and then see them to come back, for instance, a week later. Next. Patients with corona infection, non-pregnant one, have an increased incidence of deep venous thrombosis, pulmonary embolism, and stroke. From Italy, we know that patients, indeed, also pregnant patients, have an increase in deep venous thrombosis. So should you, after admission, give them low molecular weight heparin? In Asia, they don't do so because in Asia, the incidence of thrombosis is very low. In Italy, because of the cases in pregnancy with an increase in deep venous thrombosis, they do give low molecular heparin in admitted patients only, not in the low risk, not in the ones with mild symptoms who are treated at home. Next. Timing of mode of delivery. That will be for sure early in those who are severely or critically ill. If they have severe respiratory problems, they might need delivery because ventilation of the lungs will be better when the baby is out. So these will be the cases that might need early delivery. In that case, it will be a cesarean section. Most doctors think that we should give corticosteroids in these cases for lung maturation, but there might not be time to give so because the patient might already be ill too critically. So we cannot wait to see the effects of antenatal steroids. For other patients, should it be a vaginal delivery or cesarean sections, most doctors think it can be a vaginal delivery. Data from Brescia in Italy, where they have many patients, they only do cesarean sections in case of severe respiratory failure. Internationally, there is now a discussion, what do we do with mild to moderate cases who are more or less at term, and many think that we should induce labor, because usually coronavirus infection for the first 5 to 7 days is rather mild, and then severe complication may start after day 6, day 7, with severe respiratory problems. So if they're early in the disease, you might be able to induce labor to deliver the fetus before the woman may eventually go in a severe disease process. Next. Also in China, where they do a lot of cesarean section, this is the Chinese expert consensus. You can see underlined the route of delivery, and delivery timing should be individualized based on obstetrical indications and maternal fetal status. And on one of the first slides, I showed you that in my country, the majority of these women have thus far delivered vaginally. Next. Labor and delivery. Well, if women have a confirmed disease, triage is very important, and they should be kept completely separate from the other women in the different labor room. But what about asymptomatic women, women who apparently are healthy, have no symptoms of a disease? Next. And this is a very worrying slide from New York, published 2 days ago in the New England Journal of Medicine. 2 hospitals in New York, they screened 215 pregnant women who delivered. All had a nasopharyngeal swab. 4 women had fever on admission, and all 4 of them were positive for corona, but another 13.5% without symptoms also were positive for corona. And there are more doctors who think that pregnant women may have the disease without having symptoms much higher than in the general population. But this is a problem. I know there are many patients in New York, or many people in New York who are carrying of the corona disease. I don't know how the actual situation in Egypt is. If it is a very low incidence in the population, I mean, you can consider patients admitted in labor without symptoms to be most likely negative. But if you can afford it, then screening for the infection at triage, at intake, would be favorable. If you look at these data in New York, next slide. Next, please. If you look at the data from New York, over there, they definitely have to test everyone so they can isolate also all those pregnant women who don't have symptoms early in labor, but who are positive for coronavirus infection. Next, please. The logistics are very important, and there are some publications on the logistics at the labor ward, because you have to keep these patients separate from the others. You have to have doctors, nurses dedicated to these patients. All the material that goes in and out of those labor wards should be completely separate from the other ones. Logistics, according to the data from Italy, logistics is the most difficult in the labor ward. So please study these publications on logistics and discuss it with all your staff. Epidural, no problem, can be given. Is there an increase in fetal distress? With coronavirus, it might be, because there might be maternal hypoxemia. There is an inflammatory process, which may also affect the placenta. And if they have fever, there is an increase of oxygen consumption. The data from Beijing show indeed there is a high incidence of fetal distress during labor. They give figures of up to 10%. But again, Brescia, Italy, and this was a webinar a couple of days ago, they did not find an increase in fetal distress during labor. So overall, I don't think it's a major problem. In women with corona with minor symptoms, I don't think it's a major problem. But of course, if they have moderate to severe symptoms, the risk of fetal distress will be increased. Next. These are the operation logistics just published in the American Journal of Perinatology. It is free online. I'm not going to discuss it, but this indicates how should you cope with the substerile scrub area, intraoperative area, postoperative area, and this specific one is for the operation room, but there's also one for the labor room. Next, please. Next, isolation in negative pressure rooms and or in the operation room. As said before, if available, yes, please. Otherwise, we have to do without it. Next. And this is again from the publication from Poon et al. From Figo, published in the National Journal of Gynecology and Obstetrics, intrapartum and postpartum management and triage of these patients. They should wear a mask. They have to have a special hand hygiene. The team should use protective clothing. Whole teams have to be notified. Limit visitors, inter-party management, no family around, which makes labor very difficult for these women. As indicated, analgesia, whatever they want to have, it should be given. And those are the most important ones. Next. Breastfeeding after delivery. In general, it has more advantages than disadvantages, and that's also in case of corona. But it's logical that if mothers are severely or critical you will have to separate them from the newborns. You may use a breast pump to still obtain some milk. With asymptomatic or mildly ill women, most people think that breastfeeding and room-in may be considered. The women should do a careful hand washing and wear a face mask, and the baby cot, if placed in the same room, should be at a distance of more than 2 meters. Generally, the milk is not infections, it's the mother with her breathing and her aerosols. That's the important aspect. Next. Neonatal care in women with suspected or confirmed COVID cases. I'm not going to discuss it, but please look at this paper published in the International Journal. Next. Next slide, please. Finally, healthcare workers assigned for care of corona patients should preferably minimize their contacts with other patients and other healthcare workers. So you have to have a dedicated team in the labor ward, but probably also antenatal care and care at the ward for healthcare workers dealing with corona patients, if possible. They should wear appropriate personal protective equipment, respirator that holds for during incubation and also during the second stage of labor. Otherwise, a surgical mask will be sufficient. Goggles, face protective shield, water-resistant surgical gown, and gloves. Next. In case you have a healthcare worker with corona, they have to be at home, of course. You have to test them 10 to 14 days after recovery. And with 2 negative tests, they may go back to work. In the United Kingdom, they send them back to work after 7 days, but most people think that is too early. Next. And that is my final slide. As you can see, we're still in the beginning in many countries with corona and pregnancies. So this lecture might be already outdated tomorrow, since new publications are being published almost every day. But up to what we knew yesterday, this is, I think, the up-to-date status on how we should manage corona in pregnancy. Thank you very much for your attention.
اهلا بحضراتكم تاني. انا طبعا سعيد ان انا معاكم، واسمحوا لي ارحب ببروفيسور فيسر. Hi Gerald, how are you?
Not bad. Very good to hear from you. I'm well. I hope the same to you.
I was really amazed by the presentation. It's very, very nice. And I'm sure everybody has learned a lot. I think we have more than 600 viewers. So I'm sure that they all benefited from it a lot. So
That's a lot.
I gave a
600.
presentation. Yes,
Very
I gave a
good.
presentation about fetal growth restriction, and then you gave the presentation about COVID-19. So we have questions on both presentations, and I'd like to take the chance that you are with us as regards IUGR first, because of course you are one of the world figures in this field. So there are some questions on fetal growth restrictions. I'll start by asking you about them, and then me and you can have some discussion about it, and then we will go to the next part, will be the COVID-19 and pregnancy. Is it okay?
Mm-hmm.
Okay. The first question is, what's the relation between gestational hypertension and fetal growth restriction? And is a woman with a high blood pressure higher possibility for fetal growth restriction, and how to avoid?
Do you want me to give an answer?
Yes.
Well, on the first question, I didn't hear the second one, but the first question, what's the relationship between pregnancy-induced hypertension and fetal growth restriction? There is a very strong correlation at early gestation, but at term, there is no correlation anymore. If you look at preeclampsia at 40 weeks of gestation, 10% of the fetuses will be found to be too small, which is normal, like in the normal population. But if you look at 32 weeks, or let's say earlier 28 weeks of gestation, about 80% of true IUGR patients, the mother also will have pregnancy-induced hypertension. So at early gestation, yes, and gradually that fades out, at term, not.
So in my presentation, I classified fetal growth restriction into two types: the early IUGR, or the early FGR, and the late FGR, which is the borderline would be 32, 34 weeks. So the early fetal growth restriction, which is usually early, usually more severe, usually associated with more comorbidity and mortality for the mother and for the fetus. This type of early fetal growth restriction is the one that is very commonly associated with pregnancy-induced hypertension, and possibly they have a common pathogenesis, in a way to speak. While late fetal growth restriction, which appears later on in pregnancy, usually is not associated with pregnancy-induced hypertension, and usually is not caused by the same pathogenic pathway. Would you agree on that?
Yes, in that way, early growth restriction is rather easy because they generally have an abnormal flow velocity in the umbilical artery. Late IUGR is very difficult because we don't know if a baby is very small at around the third centile at 38 weeks of gestation. We don't know if that one is IUGR or just genetically small for dates, since most Dopplers will still be normal. Redistribution may help, but we don't know if that works in all cases of true late IUGR. On average, what we know is that if the fetus is indeed very small, with a weight below the third centile, estimated weight, then the risk of asphyxia is increased. So we should consider them at higher risk. If they also have signs of redistribution, they're most likely true late growth restrictions. But if fetal weight is around the 5th centile, and we don't, and the Dopplers are normal, we don't know yet. So from the Netherlands, from the randomized trial on fetuses with the weight below the 10th centile after 30 weeks of gestation, after 36 weeks of gestation, we found that best outcome generally occurs if they don't labor spontaneously to induce labor at or a little bit later than 38 weeks of gestation. But the late IUGR, we still don't know exactly how to identify these cases.
Okay, the second question is this statement is correct or not? The middle cerebral artery Doppler is not indicated unless there is umbilical artery Doppler changes.
Sorry, once more, please.
So, middle cerebral artery Doppler should not be measured unless there is umbilical artery Doppler changes.
That's not true. Let's say an early gestation, early IGR before 34 weeks of gestation with abnormal umbilical Dopplers. In fact, there's no need to measure middle cerebral artery because you delivered them based on fetal heart rate monitoring and also on ductus venosus. So in late IGR, let's say 38 weeks of gestation, you're very unlikely to find an abnormality in the umbilical artery. So in those cases, if you have an abnormal velocity in the middle cerebral artery, it might be indicative. And if the fetus is small and there is an abnormality in the middle cerebral artery, then it's likely that induction of labor improves outcome. That does not hold for fetuses with a normal weight and an abnormality in the middle cerebral artery. That is most likely a chance finding.
There are actually 2 or 3 questions here about treatment of a fetus that is already diagnosed to be fetal growth restricted in pregnancy, and the questions about low molecular weight heparin, sildenafil, other methods of treatment. As you know, it's many areas of the world, especially here in Egypt, people use a lot of medications, in particular low molecular weight heparin, to treat IUGR fetuses or even to prevent intrauterine growth restriction in some cases. What do you think about first treatment of an already diagnosed IUGR fetus with low molecular weight heparin or sildenafil or other medications? And the other half of the question is, can these drugs be helpful in preventing intrauterine growth restriction in high-risk cases?
Thank you. I could hear this question really well. Low-dose heparin, in my opinion, there's no indication for it, maybe only in women with lupus disease or other specific diseases. But there is no evidence that it works. Of course, recently we had the Viagra in the treatment of severe IGR, also that did not work at all. Okay. So the only thing, early screening for preeclampsia is early start with low-dose aspirin, and that may reduce the incidence of preterm delivery because of preeclampsia and or because of early growth restriction. That has been proven, but that for the time being is the only thing we can do. In the 1990s, women were given oxygen to breathe, but it doesn't have any effect yet. Prevention of the disease, and thus far that's only possible prevention of early IGR by preventing early preeclampsia. For late ones, we're not that far yet.
Okay, so I always say that in my presentations, but I'll confirm what you have said, that once you diagnose fetal growth restriction, actually the treatment is monitoring until the safest time of delivery can be achieved, balancing between prematurity and intrauterine or peripartum complications. There is no role for medications. whether it is low molecular weight heparin, Viagra, or any other drug that will help treat these fetuses in this condition. Would you agree?
I fully agree. But doctors always want to treat. They think they're a better doctor if they give medication or whatsoever. But I think doctors should explain to their patients that nowadays we don't have specific treatment options once there is a severely growth restricted fetus.
Thank you. Now we'll come to the questions about COVID-19 and pregnancy, and the question about treatment of COVID-19 during pregnancy. What are the drugs available? Is it safe or not? And is it effective or not? I know it's a very complex question, and I know that you somehow try to avoid talking about them because, as you have just said, this thing changes every day, actually, every minute. What's the medication, what's the right? And we all know that now treatment of COVID-19 is not decided by doctors, it is decided by politicians. As we can see from the States, they are now putting the treatment of COVID-19 in general into action. So what do you think about drugs that has been put as suggestion, and how safe they are and how effective they are during pregnancy?
Well, in the United States, they have a very important obstetrician. His name is Trump, and he thinks we should all give these patients chloroquine, an anti-malaria drug. But I don't think there is any strong evidence. There are people who give anti-tuberculosis vaccination, and that might help in the general resistance. We don't have evidence. There are no trials in non-pregnant women, in non-pregnant patients, giving corona antibodies that come from corona-positive ones. And the first trials have started, at least in my country, but we have no idea yet whether or not it helps. So the clear answer, in my opinion, is no proven drug to treat the disease. Symptomatic treatment.
If you're going to give these medications that they are promoting, the hydroxychloroquine, the azathioprine, azithromycin, or the antivirals, is it safe to give them in pregnancy or not?
I don't know. I don't have the experience. With chloroquine, it might not be safe in pregnancy. For the other ones, I can't give you an answer. I wouldn't treat them at the moment. If there is a real option, then we should discuss and see whether it is safe in pregnancy. But nowadays we don't have proper options.
There is a debate about breastfeeding and rooming in, and you know that in the States and in Europe they are encouraging breastfeeding and rooming in. But the experience from China is that they do separation, or at least the series that has been published, I know it's small, but they are encouraging total separation for 14 days. So here it's a common question, actually. A woman with a positive COVID-19 and she has delivered, even if she's going to put a mask, but I mean, she's in very close contact with her baby. So definitely there is a high risk that this fetus or newborn will get the COVID-19 from her. Despite that, in the United States and in the United Kingdom and in Europe, they are encouraging rooming in and natural breastfeeding. What do you think?
That's true. The Chinese came very early with their regulations, and then we knew less about the virus, then we also knew less about vertical transmissions, etc. And so the Chinese were very careful. They said, yes, we have to separate the newborn. But nowadays, we are a couple of months later, and we don't see newborn diseases. So indeed, that's why in Europe and in the United States, we think, yes, you can do a rooming in, but the cot should be at a distance. The breast milk is not infection, so the mother has to wash her hands very carefully, wear a face mask, and then might be able to give breastfeeding. That's what we think at the moment. I don't think there have been disasters with this policy, so it seems possible. And I think for the woman, it might be important because her husband is out, he's not allowed in, so at least let her be together with a newborn baby. But tomorrow, also that opinion might be different.
Okay. There is a question about isolation of doctors and nurses who deal with the corona patient. I think you have talked about that, but here in Egypt, the situation is a little bit different. In Egypt, if you have a corona patient that is tested positive, she's not treated in the same hospitals anymore. She goes to what we call quarantine hospitals. We have hospitals like this everywhere in Egypt, and women or patients in general would go to these hospitals, and even if they are pregnant and they deliver in these hospitals. And no visitors are allowed, no accompanying persons are allowed, and the doctors there are a team that is there. They don't leave the hospital unless they are checked. So it's a little bit different, the situation here. I know most of Europe and most of the states, they have the same hospital, but different areas. Area with patients and area without patients. But here we have done hospitals. But I think this is the reason. The reason for that is that we still have small number of patients. And as regards your question, there are two answers to your question about the situation here in Egypt. Let me answer that. And I know that the issue of small number of cases in Egypt, because we don't test people who have mild symptoms, we don't screen doctors or nurses who are working in general hospitals. We test only patients with severe symptoms, patients with symptoms that are admitted to hospitals that are suspected of having COVID-19, and those who are in contact with positive patients, whether they are relatives, friends, or doctors. And this is one of the reasons we don't have a large number of positive cases. But from the number of mortalities that we have, I think if you consider case fatality rate around 1%, 2%, or even 5%, that means that we have a larger number of cases, because once you have mild symptoms, you are asked to self-isolate at home without testing. So this is one of the reasons we have smaller number of cases in Egypt compared to the population and compared to the number of fatalities or mortalities. Yeah. So the issue is different, but of course we shouldn't.
The management, with your management, that if you have positive pregnant women, if they can go to a special hospital, not to the general hospital, that's much better, because then there's only a certain number of nurses and doctors dealing with them. The problem is with the so-called low-risk cases. They've not been tested, they have no disease, but they still might be positive and they might be spreading the virus. If you can test them when they come into the hospital, that would be ideal. If you can't, it's a serious problem.
Okay. A question about antibody testing. If you are screened and you have antibodies, whether IgG or IgM or both, would that mean that you are immune and you can go on and work or return back to normal life? Because there is a lot of talks about that in the USA and in Germany, and there has been some voices here in Egypt saying that we should test for antibodies and see who is positive and who is negative. What do you think about that?
Yes, there is a debate. I don't know. I guess if you have the IgM ones, which are the most important ones, that you're likely immune for the time being. Probably only for the time being, because also with influenza you may get it again in a year from now or not. But no one is sure yet. If you have a low concentration of IgM, then you still might get the disease. after a very short period of time. We don't know. But I think if you can measure it, and you have a reasonable amount of IgM and IgG, then for the time being, at least I think, and also I hope I should say, that you can't get the disease for at least a certain period of time.
Okay, I think this will be the last question, and I'll go back to IUGR because actually this is something I know that you would be interested in, about delivery of gross restricted fetuses. In Egypt, you know, and I have seen your presentation about the cesarean section rate in Egypt, any fetus who is gross restricted is delivered by cesarean section. Whether it is small for date, fetal gross restriction, whether there is abnormal Doppler or Doppler change, actually this is a say here in Egypt, in most of the medical field, that it's better to be safe than sorry. So it's better to deliver everybody with a cesarean section who's suspicious of being a fetal gross restricted. In my presentation, I gave what I think is the internationally accepted indication for cesarean section, but please, if you can summarize in 2 minutes, when would you do a cesarean section in a gross restricted fetus?
Yes, I would like to. Let's start with early growth restriction. There are abnormalities in the ductus venosus. There are fetal heart rate decelerations, reduced variation, all before 34 weeks. If you have signs of hypoxemia before labor, that implies that you have to deliver the fetus by cesarean sections, and the fetus should not go through the process of labor. We know, on the other hand, if you have a small fetus, at term, 38 weeks, weight at the 5th centile, if the heart rate pattern is normal before the labor, then the vast majority will sustain the stress of labor. And there is no difference in outcome, at least not in my country, the studies that we have, in those delivered by cesarean section of vagina. So yes, you have to monitor during labor, but they're supposed to be able to sustain the stress of labor. In between 34 and 37 weeks, it's a little bit in between. If you diagnose an IUGR a little bit late, and at 35 weeks, you find an absence of the end-diastolic velocity, or even a reversed end-diastolic velocity, so severe changes that usually occur earlier, I also would deliver them by cesarean section. But in case of the presence of end-diastolic velocity, in case of normal fetal heart rate tracing, yes, induce labor, but monitor them with continuous cardiotocography. That was in less than 2 minutes.
There is a question, actually it just came in, and there is Dr. Yahya. He is asking about early or late FGR, and I said that early is worst, and he thinks that you said that the early IUGR is better.
No, early is more severe. These ones are also procentually, they're much more growth restricted than the late ones. They may have a weight which is about only 50% of that of a normally grown one, the early. In late IUGR, related to prematurity. Early IUGR is severe. Screening and early pregnancy, preeclampsia screening and early pregnancy, we may prevent quite a number of the early gross restricted fetuses nowadays.
So early IUGR is worse?
Yep.
Okay, because I don't know why he got this impression from me and you, but this is how we get. So actually, I think we have answered. There is the final question. Again, this is very good. What about a woman who is planning to get pregnant now? What would you advise?
Sorry, once more, what about?
What would you give an advice to a woman who's getting pregnant now or planning to get pregnant now? A woman who is trying to get pregnant, a woman who wants to do ART, IVF, XD, induction of ovulation. Is it the right time to do it or should we wait?
I think it's a very good question, and I must say I don't know. Thus far, there are no data that indicates that the severe corona infection in early pregnancy may cause fetal abnormalities. But we don't know yet. Since the number is so low and the disease is only existing for 3 months, so many women who might have had the disease in early pregnancy have not delivered yet. So
they have not even reached the level to do the anatomy scan yet.
Yes, you can, at least on the anatomy scan, you don't see it, but what about more subtle abnormalities? High fever in early pregnancy may induce subtle abnormalities. Overall, I would not be too worried, but I cannot substantiate it.
So I think, would you think that, something to say like a woman who is not doing anything to get pregnant, there is nothing we can tell her now that you should not be pregnant. But a woman who's going, for example, for an IVF, I think she can wait for 1 or 2 months so that the picture is better. I mean, would you agree? I mean, if you're going to do something to get pregnant, invasive, and you'll go to the hospital and take medication, it would be safer to wait for a couple of months. But if you're just not doing anything and not using contraception, we cannot tell you what to do. I mean, you can more or less, hopefully, everything will be fine.
Professor Montas, I fully agree.
Thank you very much, Professor Visser. It was a pleasure seeing you online, and I hopefully we can meet soon. I know that you were coming to Cairo last month, but unfortunately it didn't work. So definitely we will see you soon here in Cairo. And thank you, really. We enjoyed your company and enjoyed your presentation. Thank you very much.
The pleasure was all mine. Thank you very much for the invitation. Thank you.
بنشكر حضراتكم جميعا وكل سنة وحضراتكم طيبين. اخوتنا المسيحيين اعيادهم طبعا بكرة وبعده.